joining us at our Women's Health Mixer with the lovely Dr. Sherry the Shack, the owner of She Fit Physical Therapy in Mission Valley and PB. All right now, so Dr. Sherry, please share with us about your history, what brought you to women's health and pelvic floor and PT and all the work that you do and your lovely staff. And then, of course, we want to field questions from everyone in our audience today. So, Dr. Sherry.
All right, here we go. So we talked about, for those of you that are here, I tried to print my notes, but my printer doesn't work. And so I have them on my phone. So I'm not looking at my phone because I'm rude. I'm looking at my phone because this is where my notes are. So who here knows like where their pelvic floor is, what all the muscles are called, and you could like contract and relax your pelvic floor while you're juggling eggs and drinking wine?
We work on that.
Versus like who has no clue what your pelvic floor is and is so embarrassed right now and just like wants to crawl under a rock and never speak of this again.
I'm half.
Okay, 50-50, right? Okay, so I was always the girl growing up who was like so modest and wouldn't even like change in the gym. Like I had to go to the bathroom to change my clothes. Like I was always the most modest person. And still am that way until I breastfed 3 babies. But of course, like the Lord had it planned out for me to specialize in like the most taboo, like sensitive thing you could ever possibly specialize in as a physical therapist. But about a year, I probably started specializing in pelvic floor PT about a year after I graduated from PT school. And when I was in PT school, I didn't really have any interest in pelvic floor. All I knew is that like the lady came and talked to us for a couple hours and she mentioned like pee and poo. And I was like, well, I went to PT school so I wouldn't have to deal with bodily fluids. Like I have a sister who's a nurse. My mom was a bio major. So I'm like, this is not what I'm going to do. But within a year, about a year after graduating and starting to work, I started taking some of the courses and I just fell in love with it. And I just never looked back because the amount of information that we do not get as women about our bodies and all of the changes that they go through like from obviously in puberty, but then through the childbearing years and then approaching menopause and then through, you know, the menopause phase and then post-menopause, the amount of information that we don't have, but then when you are able to give someone that information, like the life-changing impact that it has is like so rewarding. I could never go back to like treating ankle sprains and rubbing people's tendonitis. Like I just could never do it. The first few clients, it's like, oh my gosh, I can now go back to the gym without feeling like I have to wear a pad or always black yoga pants because I know I'm gonna pee my pants. Or I can like lift my baby now without farting, or I can like be intimate with my spouse again without having my like being terrified that it's going to be painful, right? So these things that are so intricate in our lives, and really for us as PTs, like they're usually often very simple to fix, and yet so many women never even get to us to just learn like these simple things. So I started out taking pregnancy and postpartum courses, and then I took like the whole spectrum of pelvic floor, basic pelvic floor intervention courses, and I just continued to add Con Ed on top of that. And I worked for another company, an orthopedic company, for a few years, and then I realized, it was a great clinic. They were an insurance-based clinic, so I got 20 to 30 minutes with my client. And for a pelvic floor complaint where you're talking about like the most sensitive issues in your life, it's just not enough time to give that person the quality that they need. And so I decided I was gonna go off my own, ditch that model behind me, and like be able to treat the way I want, which is to spend like a whole hour with my client and really talk through the entire history and everything that's going on and everything that might be contributing to this problem that's not just so simple, so that's kind of how I got my start. And then I grew in PB. Actually, initially I started out in PB and eventually just kept growing and started hiring staff, and we opened a satellite clinic in Mission Valley, and then now our main clinic is in Mission Valley. So I have, how many do I have now? I think we have 8 therapists now who are all pelvic floor specialists. So the field has like exploded since I started. There's way more pelvic floor therapists out there now than there were 10 years ago, which is great because people are like finding out about it. And so there's more demand, there's more people getting the education, and there's a lot more people like getting care, which is wonderful. So a lot of the things that like, does anybody know, like what are some of the things that you would think would drive you to see a pelvic floor therapist, like symptom wise?
Maybe after pregnancy?
Definitely after pregnancy.
After hysterectomy.
Definitely after hysterectomy. Anything else that you'd think, oh, you might need pelvic floor PT?
Endometriosis.
Definitely endo. So yes, chronic pelvic pain of any kind. So what about postpartum, do you think? Like what about postpartum would trigger like, oh yeah, you should go see a pelvic PT? Diastasis recti. So any kind of core weakness
issues,
really, because your abs are like all stretched out, right?
Peeping, pooing, if you can,
No.
incontinence, really.
Or maybe like when you hold your urine for a long period of time, I don't know.
Yeah, so I was saying you're not allowed to answer.
Oh,
no,
sorry,
already.
look at me.
Yeah, so anything that has to do with, you know, the bladder, the bowel, and the vagina, and the abdominal wall, like all of that is
Straining,
our
stuff like that.
wheelhouse. Yeah, so I think a lot of people don't realize that, you know, if the vast majority of people don't realize that they should see somebody pregnant or postpartum because they just never get told like, hey, this is something that you can do. Nobody comes in to see us until they have like a major problem and they finally can't live with it anymore. And so they go tell their doctor after 5 years of dealing with it, they tell their doctor, and then their doctor may or may not say, hey, why don't you try pelvic floor therapy, right? A lot of times, you know, if it's just very mild postpartum, then people just kind of deal with it. They figure, well, maybe it'll go away, or I can live with this, or this is just my life now as a mom. And then they hit that perimenopause stage, and now all of a sudden those mild symptoms become very bothersome and problematic. And now they're like, okay, I don't want to deal with this anymore. Like something is really wrong. And so then they'll finally go to their doctor, like approaching 40s and 50s, they'll finally go to their doctor. And sometimes the doctor will tell them pelvic floor PT, which is great, but very often they'll offer them a medication, they'll do a bunch of tests, they'll maybe like talk about surgical options, if it's a prolapse or a bladder thing. So sadly, not everybody even at that point gets told like, hey, this is an option. But really, you know, we'll talk in a second about the anatomy of the pelvic floor and how it's like so integrated in with your bladder and your bowel and your reproductive system. But what a lot of people don't understand is that in our bodies, like these bladder and bowel and reproductive symptoms, they have a lot to do with the muscles and the nerves and the ligaments and like the tissues that surround them and support them. The health of the systems is very integrated. So you can't just separate it and say like, well, pelvic floor is musculoskeletal, so that's over here. Bladder is over here, bowel is over here, and then sexual function is over here. And like, they never have anything to do with each other. Like they're extremely integrated with the way our bodies work. So a lot of the issues we have with sexual dysfunction, especially bladder and then bowel issues, they are related to the way the pelvic floor is working. And a lot of times it's the way the pelvic floor is working with the rest of the systems in your body. Any questions so far?
I do. What do you mean by sexual dysfunction?
Yeah, so big symptoms. So I asked you guys, so now I'll give you like all my list of 20 things, right? So big symptoms that you'll see that are an indication something's going on with your pelvic floor are going to be any kind of bladder stuff. So it could be urgency, like you get like a really strong urge to go and you feel like you can't hold it. Sometimes people will leak, sometimes they won't leak, but it's just a very strong, uncomfortable urge. Or it can be high frequency, so normal frequency for urination is every 3 to 4 hours. So if you're going more than, if you're going every 30, 60, 90 minutes, that's high urinary frequency. So that can be related to pelvic floor dysfunction. Obviously,
Question.
Yeah.
Sorry, is that correlated to the amount of water that you drink during the day?
It can be.
Okay.
But so that's always a question that we ask, like,
Okay.
well, how much are you drinking? And
Okay.
what are you drinking? Because there are substances that can be bladder irritants.
Got it.
So it may be that you're actually dehydrated because you're afraid you're gonna leak. And so you're drinking not much of anything except for your coffee, which makes you more dehydrated. The coffee is a bladder irritant. And then the dehydration changes like the pH of the urine, so that can also irritate your bladder. So it's like this vicious cycle. So we had talked through all those things, right, when you have a problem like that. But frequency, urgency, and incontinence for sure. So if you're leaking urine, leaking of any kind, cough, sneeze, laugh, jump, lift, any of it, like none of it's normal. None of it's just like a natural sequela of having a baby. Like it's not normal. And so leakage of any kind is usually related to the pelvic floor. Bowel, especially like pain with bowel movements, hemorrhoids, constipation, those can all be related to the pelvic floor. Fecal incontinence, incontinence of gas, so like you can't hold, like we call, well, those are two different things actually, but like queefing during yoga is one thing we hear a lot from postpartum moms. And then the incontinence of gas, where you can't hold gas in when you would like to, right?
Okay, 1 second.
Yeah.
Do you guys know what queefing is?
I've heard of it.
Kind of a trendy term, right?
Yeah. No? Okay.
Basically
So queef-
farting, right?
Well, it's air coming out of the vagina.
Oh,
So normally our vagina doesn't
So like
really
a
have a whole
bubble.
lot of air
Like
in
a
it,
bubble.
right? Like a bubble, exactly.
Yes.
So when you don't, and it happens the most frequently postpartum
So
because
far
everything's
within
loose.
your
Yeah.
Yeah, exactly. So everything's like loose, the air gets in, and it happens a lot with yoga because down dog,
Yes.
like going in and out of down dog position, the vaginal tissues will move around, let some air in, and then you move in a different position and now the air comes out. And it's very embarrassing for people, right? When your booty's in the air and that happens. So all of the bladder and the bowel stuff, and some of the other symptoms that people notice are gonna be, so you can also have pain with or before urination. That's a symptom when the bladder is full or when you actually urinate, you're having pain. Frequent UTIs, vaginal and rectal pain. So oftentimes that's going to present as like pain with intimacy, can be pain during or after orgasm, but just pain with penetration. And then rectal pain often will just come on like viciously in the night for no reason. Like people will just get these spasms that feel like they're really deep in the buttocks, and those are often pelvic floor spasms.
wow.
Sometimes with that can come like some sciatica, some like deep hip pain you might have, difficulty with arousal and orgasm, and then the musculoskeletal symptoms are often things like back pain, hip pain, deep pelvic pain. So because these muscles, we'll look at the anatomy in a second, but they're very close to your hip joints and they connect with some of your hip muscles. And so often spasm in the pelvic floor feeds out into spasm in the hip. And so we'll often have people come into our clinic where, you know, they've seen physical therapists for their hip pain and their sciatica, and they got like 80 to 90% better, but they can never get like the last little bit, like it just won't go away. And it's because there's a pelvic floor component that the orthopedic therapist like can't get to or doesn't know how to get to. The last one I have on my little list here that I don't want to forget to mention is prolapse. So prolapse is another one of those things where oftentimes women might have a mild one postpartum, and so it doesn't really bother them. But then when you hit perimenopause and menopause, because of a lot of the hormonal changes, it will become very bothersome. And so that's when people are going into the gyne or the urogyne and asking like, what is going on with my body? So prolapse is where you have laxity in the vaginal walls, and so either the bladder or the urethra or the rectum, very rarely the intestines, more often the uterus, are kind of sinking and settling down into the vaginal space. And so you feel pressure, heaviness, like something's falling out. Sometimes people say they feel like they're sitting on a ball. Again, intimacy can become uncomfortable because of that. So prolapse is another big one that will show up oftentimes later. So the symptoms often come on gradually over time, especially when you're not talking about like the immediate postpartum period. They'll come on kind of gradually over time, or a postpartum symptom that maybe you had initially, but then it went away. And then as you approach perimenopause, it will start coming back again because of all the hormonal changes, which we'll talk about in a minute. But sometimes they do come on suddenly, because I definitely had clients where they had no prolapse symptoms and then they did one thing that was overexerting, like they went to a new workout class, or they tried like they decided they want to train for a marathon, and so they really upped their distance on their mileage, or they did something that just made their body mad enough that they got really symptomatic all of a sudden.
Trampoline does it too, right?
Does what?
Exacerbates the problem.
It could. Yeah, it could. It doesn't for everybody, but there's a lot of factors, but it certainly could, especially if you went from not trampolining and then you decided to take 3 grandkids to the trampoline park and you did it for like 2 hours, you know, and you weren't prepared for that, it could certainly exacerbate it then. Yeah, so it's all about building up to things, right, that we want to do. So one of the things that causes this, especially later in life around perimenopause, is going to be that drop in estrogen. So everyone knows this is what happens like around menopause, right? But everyone thinks of menopause as being kind of in your 50s. Our estrogen levels start dropping like 30s, like late 30s. It's gradual over time, right? And our progesterone starts changing and our testosterone starts changing and everything's kind of gradually changing over time. We don't realize that it's happening and we just start having these vague symptoms and we just figure like, I'm getting older, I'm tired, my kids are bugging me, like, you know, whatever it is that's causing these gradual symptoms to come on. And then all of a sudden we wake up one day and we're like, what is this body that I suddenly have? You know, but it's really been happening gradually over time. So the drop in estrogen can cause a lot of things. One of the biggest ones with the pelvic floor in particular is we know that estrogen, and I'm sure you've talked about this with everybody, we know that estrogen is going to cause, loss of estrogen is going to cause a gradual loss of muscle mass. So it makes it harder for you to maintain strength as your estrogen taps down. And this is in all of our muscles throughout our body. So as you drop in estrogen, it's harder to maintain muscle mass. Well, one of the things that helps support your bladder and your reproductive organs is the muscle mass of the pelvic floor. So as that goes away, just like it's harder to maintain your glutes, your quads, your abs, like it's harder to maintain everything as we get older, it's harder, like you have to work harder to maintain that muscle than maybe you did 10 years ago because of the drop in estrogen. It also is going to cause reduced lubrication in the vagina. So all of the nice, healthy mucosal, you know, lubrication that we have throughout most of our lives, when estrogen starts to tank, you lose that. And so what happens in the vagina in particular is that you have more friction because the tissue is not as moist. And when you have friction, like imagine when your like lips are kind of chapped and you like smile or you rub them together, like it's not real comfortable. Whereas when they're nice and moist, like you don't even notice your lips are there, right? So as the vagina gets dry, you feel things more. And so that's another reason why you might start to feel a prolapse. Even if it's not any worse than it was 10 years ago, you start to feel it because your vaginal tissue is more sensitive. So sometimes that sensitivity and that dryness can contribute to some discomfort with intercourse, with penetration. And so if you have that dryness and that friction, well, now it doesn't feel good. So now your muscles are kind of tensing up and you're like, well, I'll just stick it out. Like this is what we're doing right now. So I'm just going to get through this. But then as you do that over and over and over again, your body starts to anticipate that discomfort and your muscles start to guard preemptively. Now you're having muscle spasm on top of the friction that was already there. And so you get into this cycle of pain where the pain is getting worse, the vagina is getting drier, right? So once you have that muscle spasm present, even if you go to the doctor and they say, okay, well, here's 3 kinds of lube you can try, the muscles are still in spasm and the lube's not going to fix the muscle spasm. It might fix the friction aspect, but it's not going to fix the spasm at that point. So we have to address that piece of it. Okay, also there's, you know, the issue of blood flow. We get reduced blood flow into the pelvic organs, which impacts the arousal response, as does the lack of lubrication. Let me just bear with me for a second here. Any questions about anything I've said so far?
I was just wondering if that, you know, with everything that you're talking about as you're going through menopause, would that cause you to like have bleeding?
Can, especially the vaginal dryness, because you can get like little like just like a braid,
like a period.
Right? Like if your mucosal tissue is very thin, it's not like our skin, right? Where it's supposed to withstand and hold up against friction. Mucosal tissue is like very prone to tearing anyway. So if it's dry and you have friction, you're not using a lubricant, that could potentially cause some tears. Also, if you have like a smaller vaginal opening, some women have, tears during childbirth that are then repaired, and that makes the vaginal opening smaller. You could get tearing if you're trying to do something and your pelvic floor is not letting go, and so you have an opening that's clenching, it's not letting go, right? And you're pushing it through anyway. You could potentially have some tearing or some bleeding. That's going to be different from like bleeding from the rectum, which could be hemorrhoids, obviously, but then also if you have bleeding from the rectum, you want to look at, okay, is there something going on further up the GI tract, right? And then bleeding that might be spotting. So obviously with onset of perimenopause, one of the things that happens is that people's periods get irregular. Sometimes there's spotting between periods, sometimes you might skip a period, it might be longer or shorter. So there's bleeding that can happen from that as well. Does that answer your question? Okay. And then sometimes also, I think like if you have a really bad UTI, you can sometimes have some blood in your urine too. And with menopausal changes and the drop in estrogen, you're more prone to UTIs because of like pH changes and acidity. And then you're also, if you have a weak pelvic floor and you have incontinence, so you're leaking, that also is going to make you more prone to UTIs being frequent because it just bacteria growing, around the opening of the urethra. So there's lots of reasons we could be bleeding at that stage in our life. Obviously, you also, if you're bleeding vaginally, you also want to get cleared by your GYN for things like, major things that I can't fix. Yeah. Okay, so we talked about increased sensitivity can cause irritability with penetration or with intimacy, so the muscles then go into spasm, and that can also irritate the nerves. So we have nerves that run through those muscles and then come down into the pelvis, and some of them come down into the legs. So your sciatic nerve actually goes right through that region. So if you have tightness and irritability in those muscles, and then the nerves get irritated, then you can have fallout from the nerves being irritated. And they will feed into that cycle as well. Okay, so we talked about loss of muscle mass may reduce the control of the bladder and the urethra. Also, the muscle bulk helps to support the bladder. Hormonal changes, talked about that. Bladder leakage contributes to, talked about that. Hormonal changes, stress and cortisol, constipation, bowel issues. Okay, so I'm gonna take a break from my little symptom tirade here and give you guys an anatomy lesson. Yeah, you question?
We just kind of poll the audience and find out, do you guys have any questions at this point, like specific to something that you may be dealing with or something that you've been wondering and don't quite have the answer or what have you? Is there anything in particular that you guys can think of? No? Okay.
No,
I just want
quick question. Even let's say, I don't think I have any of the symptoms that you have described, but do you recommend just doing exercises just as we just work out our entire body, just to learn some of them and just
Yeah, so if you don't have symptoms currently, then you're thinking from a preventative standpoint, right? Because we know that we're going to get that drop in estrogen at some point. Yeah, so so the first thing is going to be to you want to check the muscles in isolation, but ideally you want to then integrate that into your workout routine, right? So Michelle, in your workout routine, has enough knowledge and skill that she's gonna know how and when to cue you to use your pelvic floor or not use your pelvic floor. What she doesn't know is when she tells you to turn on your pelvic floor, is it actually turning on, or do you even know how to find it? So they've done studies on, training people how to do pelvic floor contractions, which in common language is Kegels, right? So when they ask people to do a Kegel, when they teach them in a verbal and a written format, this is how we want you to do it. And then they actually test what the person is doing. Only about 44% of people will actually do a pelvic floor contraction. So it's a hard muscle group to find. We can't see it. It doesn't move any joints. So it's really hard to know if you're doing it right. So that's where, when we see you in therapy, we do vaginal assessment because that's really the only place you can actually feel if the muscles are tightening or not. So we actually put a finger in there and have you squeeze, and that way we can gauge your strength. We see how long can you hold, how many reps can you do, how quickly can you fire on and off. because with different types of bladder issues, we have different findings typically. And what we find with how well you can control and coordinate your muscles is going to tell us like what you need to be focusing on in terms of or do you have great control and you just go to your workouts and like do movements with an awareness of turning it on, or do you have really poor awareness of turning on, or are you really tight and you have really poor awareness of letting go? Because if you're tight and you have poor awareness of letting go, and then Michelle's cueing you to do all these great exercises, we don't want you to then end up with more tightness. So we want to make sure that you know how to relax in between those reps. There can be things like from vaginal births where you have a scar tissue that needs to be mobilized because that's interrupting muscle function, you know. But yeah, from a preventative standpoint, you just want to double check that like you can actually find the muscles and properly activate them and then relax them again. And once you know that you have good awareness and control of the muscles, you want to integrate them with a whole body program versus just do 20 Kegels a day. Like, it's way more functional to integrate them in with a whole body program.
Got it. Okay.
Yeah. Did you have a question?
Oh no, I was just listening to you. I was taking a note because sometimes I'll forget like what you said.
Yeah. Feel free.
I've got a question for you. I've had instances where, you know, I speak to clients about going to go see a pelvic floor therapist, and they will tell me that they see a therapist and the therapist doesn't do an internal exam. Is that standard? Because I'm assuming it's not.
It's not standard.
Okay.
I mean, I don't know if there's anything that's standard in pelvic floor therapy yet.
Okay.
It's just, it is a very new, we're still a very small niche.
Okay.
And the unfortunate thing is that because it's growing so fast, we have a lot of very young therapists out there who maybe just haven't had a chance to like really fully develop their skill set yet. But we also have a lot of like larger systems and potentially larger PT clinics that are like picking it up because it's trendy. So they'll like ask one of their staff PTs, hey, will you just go take this pelvic floor course this weekend so that we can say that we offer pelvic floor therapy?
Okay.
And the person may or may not even be interested in pelvic floor therapy, but their boss wants a pelvic program, so they go do the training. They take in one course, now they can say they're a pelvic floor therapist, but they really don't have a very well-rounded view of how to address the pelvic floor, like in all the different aspects.
Right.
Because it's a lot of time.
No
Like,
doubt.
it's a lot of time of postdoctoral continuing education that we do to really get a broad understanding of it. So I would say the only time, there's a couple times where I wouldn't do a pelvic floor assessment on the first visit.
Okay.
One of those times is if the person has a lot of history of trauma and they're very anxious and fearful.
Okay. Yeah.
Then I'm like, you know what, let's just stay external today. Let's look at your posture, your breath patterns. How do you use your core? How do you integrate your hip? What is your hip range like? Like looking at other motor patterns and like other things.
Right.
Maybe we do an external pelvic floor exam to just get a visual of like how they maybe are contracting or relaxing. But we would save that internal exam for a time when the client is more comfortable with it and they've gotten to know me a little bit and they trust me, so it's not going to be so traumatic, right? So we always want the client to be ready and comfortable to do it as well. So that would be the biggest instance where I wouldn't do it on the first visit. Second instance, well, I mean, an obvious one is going to be like if they're immediately post-op, like surgery or C-section or birth, right? There's a certain time frame we want to wait before we do an internal. So 6 weeks after a vaginal birth, C-section, you still wait 6 weeks for everything to kind of like settle. You don't want them to be not bleeding anymore, you know, things like that. So there's certain time frames where they're just precautions. And then the other time is when they have a lot of complaints, like there's a lot of things going on, and we choose to prioritize other things. So like if it's a postpartum person who's got back pain and hip pain and they're leaking and they have a prolapse, and you know, like we have all these things to look at, then I might feel like, okay, our time today is maybe better spent doing some bigger picture things, and then we'll do the internal exam next time. So those would be some scenarios. But by and large, when people come to see us, like they want to find out, and so we'll most often do a pelvic floor exam on the first visit. But there would certainly be instances where you would choose not to do it for various reasons. But like if she went expecting that, I would have expected them to do
To
it.
do it.
Yeah.
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 And the reason why I ask is because, partly the reason why you're here is to help inform women as to what to look for.
Yeah.
Why would you want to go see a pelvic floor therapist? Why is it important?
Yeah.
Because in all honesty, outside of a gynecologist, the only other doctor, and I say this to you all the time, like pelvic floor therapists are made for women, honestly. You know what I'm saying? I mean, in order for you to understand what's happening in your body, so that you have a good understanding, so you can make better choices and be more informed about where you go from here. I don't know of another, you know what I'm saying, in terms of doctor that does that, that knows the woman's anatomy so intimately like a pelvic floor therapist or a gynecologist, truly.
Yeah.
So.
Maybe a midwife.
Oh yeah. I'm just gonna slide them in there.
Yeah.
Midwife, yeah, most definitely.
They're on par with OBs.
Yeah.
So, I mean, that's a really good question. And remind me to talk about like what to look for
Please.
if you go see somebody, because that is a really good question. There goes the rectum. So a little bit of anatomy for you guys. You can understand some of these words, I throw them out and then I forget that people don't know what I'm talking about. So here's your pelvis, right? So all of that red is muscle. So that's all pelvic floor muscle. So your pelvis is like a bowl, right? And then you've got this group of muscles that sits kind of at an angle when your pelvis is in neutral, and it's springy, right? So they used to always say it's like a hammock, but hammock is such a saggy analogy. Like they're springy, they're buoyant, right? So it's more, think of it more as a trampoline. And that's really more how it should behave, is like a trampoline that has a brain that can actually like think and respond to things. So it's sitting kind of there in the base of the pelvis. There's actually about 12 muscles in there, and they connect in different directions. They go forward, back, they go side to side, and there are some that are sphincteric, right? So we have urethral sphincters, we have anal sphincters, and we have, it's not a sphincter, but there is a muscle that wraps around the vagina. And then we have some deeper ones that go from the pubic bone and they wrap around the vagina and around the rectum. And these deepest ones are called the levator ani. So those are kind of the most well-known ones. Because they lift the anus, right? So a lot of times when we think of like stopping a fart in an elevator or something like that, that would be you're getting like your levator ani. If you do a pelvic floor contraction or a Kegel and you mostly feel your anus, like you mostly feel the backside, you're probably really good at contracting these muscles. So like sometimes I'll have clients say, well, I've been doing my Kegels, and it's not helping. Well, one of the reasons is because they may be contracting the backside really well, but their brain has lost connection with the more anterior muscles that actually control the urethra. So that happens a lot, after having babies, when everything's been so stretched and like disrupted in there that your brain just loses sight of like how to connect with the different parts of the muscle, and they might be inhibited for different reasons. So that's one of the reasons why you could be doing a lot of Kegels and still leaking, because you can have parts of the pelvic floor not working as well as other parts. So inside the pelvis, sitting on top of the pelvic floor, we have, in no particular order, in a very particular order, we have a bladder, right, and a urethra in the front. And then we have a uterus and a vagina that sits right behind that, behind it on top, right? And then we have a rectum and an anus that's kind of going back along the back like that. So they kind of all stack up here. Right? So you can see how the pelvic floor is like supporting, right, all of those organs. So when we talked about prolapse, right, so what happens with prolapse is one of these organs is kind of pressing into the vaginal space, and that's where you get that kind of sagging down and feeling of heaviness. So one of the things I wanted to talk to you guys in particular about is the whole body approach, right? So you're asking me like the difference between different pelvic PTs and what do you look for? Right. So a lot of clients that I see who have been to like a hospital program, they're very, very focused on doing the pelvic floor contractions and checking the strength, and oh yeah, your strength is great, and we're done with pelvic PT. You're like, but I still can't go to the gym. Like I can't lift more than 20 pounds. Like, what do you mean I'm done, right? They're just focusing on the pelvis because that's what the diagnosis is for, and so that's what the insurance is gonna cover, and so that's all you get. Right? So for us, the pelvic floor is part of a system, right? So the pelvic floor sits at the bottom on the top of this closed pressure system. You have your diaphragm, and then you have your abdominal wall wrapping around. So your abdominals, your diaphragm, and your pelvic floor control the pressure inside your abdomen at all times. And your abdomen is full of very important organs. And your brain really likes your organs and wants them to function. And so your pelvic floor and your abs and your diaphragm are going to behave in a way that tries not to put too much pressure on those things. So these muscles are controlling the pressure and easing pressure where they need to and creating pressure where they need to. So when you do something that loads, that creates more pressure, one of those muscles is going to give, right, to kind of like let the pressure out of the system so the muscles don't get, the organs don't get damaged. So a lot of times if we have a cough or a sneeze, those are big contractions of the diaphragm. And so they increase the pressure in the abdomen. And so if the pelvic floor either A, isn't strong enough to withstand that pressure, or B, like your body just doesn't like the pressure and doesn't know what to do with it, the pelvic floor might let go in that moment, and that's when you would get a leak. So other things that we took, like jumping, high impact, but it could be lifting something heavy. There could be all kinds of things where a physical stressor would cause your pelvic floor to let go, and there would be a loss of bladder control in that situation. So that's what we call stress incontinence. So when we look at this as part of a system, we don't just care we don't only care how strong your pelvic floor is, right? We care how well it's coordinating with the abdominal wall, the diaphragm, the hip muscles, everything else that it functions together with. So aside from intra-abdominal pressure, your pelvis is also where your hip attaches, right? And that's how your brain is controlling everything going down through your lower limb. So if you're standing up or supported by your lower extremity, your hip is extremely important, and your hip is attached to your pelvis. And so your brain is calculating all the time, how do I keep this pelvic structure stable to keep my whole body upright, right? So you see the pelvic floor muscles, kind of, you can see them popping through here. This is the hip joint, the hip socket, and you've got muscles that attach right on the outside of this that then control the hip. So they literally attach in with the pelvic floor. So they're connected to it through fascia, and they also are fed by the same nerves. So the hip, when your hip is moving, your pelvic floor is also contracting or relaxing in a way that facilitates your hip motion. Similarly to core stability, so like your pelvic floor is, along with your abdominals, stabilizing the whole pelvic girdle. So these are our SI joints. They're between the sacrum and the ilium. Has anyone heard of the SI joint before? You've heard of it, right? So this is a common pain generator, not only in pregnancy, but also as you get, really any time in life, the SI joint can be a problem. So the pelvic floor is one of the things that helps control and stabilize these SI joints, as well as the pubic symphysis in the front. Mm-hmm. So your pelvic floor is a core muscle. It helps to stabilize the pelvis. So when you're, for example, loading through one leg, or you're doing a squat, or you're doing a lunge, one of the pelvic floor's jobs is to help to stabilize the pelvis so the hip can do what it needs to do. So we have to look at it as a whole system. So like if you're leaking or having problems with coughing and sneezing, we really want to look at, okay, well, how is your pelvic floor working together with your diaphragm and your abdominal wall when there's a pressure from up above, right? But if you're having leakage, like when you're jumping or when you're lunging or when you're doing something with your lower body, we really need to look at, well, how is your pelvic floor integrating with your hip, right? And your coordination with movement. So it's a whole system. Like it's not just this muscle group. Right. So we want to make sure that when we look at your pelvic floor, so we talked about, like, sometimes I won't even do an internal pelvic floor assessment on the first visit, but there's so much other stuff to look at. If someone is leaking, like they don't leak at all, except when they've been running and they're running on hills, and then they get to this one point in their run where they go around a corner and then it's a dirt track, and now they leak for the next mile, right? It's like figuring out, well, why are you leaking then, right? Is it because you changed surfaces? And now your foot doesn't control well on this new surface that you're on. And so we need to work on how your foot mechanics and like all of that, all the way up the chain, right? So sometimes there's so much to look at that like the pelvic floor is not first on the list. It just depends on what's happening. I'm rambling like so bad right now.
No, I mean, it's...
That's really good though to know, because like I remember my grandmother towards the end of her life, she was leaking a lot.
Yeah.
Bedwetting and, you know, I mean, she obviously was older, but I'm not sure how long that was going on, so.
It probably gradually got worse and worse and worse year over year, you know, and it is, unfortunately, it's one of the most common reasons that women will go into a nursing home is incontinence, right? And none of us really want to end up there, especially not sooner than we have to. So making sure that we have control of our bladders and we stay continent for as long as humanly possible is actually really important. And from the perimenopause perspective too, like, you know, Dr. Rachel Rubin talks a lot about like hormone replacement therapy and getting estrogen back in the system so we can prevent UTIs. Pelvic floor is part of that, right? Pelvic floor is also part of preventing the UTIs, because if you're leaking a lot, you're more prone to UTIs. And if you're in a nursing home with a UTI and no one's, you know, you're not getting changed or something frequently enough, like people can die from that. So it's a bigger deal than just, oh, I pee when I sneeze, haha, I guess I'll just live with that for the rest of my life. Like it gets worse at some point.
So,
which is funny though, because I feel like all of my friends, it's just like so normal. They're like, yeah, we just pee when we sneeze.
Yeah.
I'm like, okay, I guess I'm starting having a kid, but I guess not normal.
So now you can go back and tell them, like,
you guys are crazy.
it's super common. Like it's super common for all the reasons. Like I haven't even talked a lot about postpartum, like all the different types of birth injuries and the reasons that postpartum people might leak. But really, like, this is my like mission in my career is that, like, women should not be writing this off in the early phases and just saying this is normal and then not addressing it for 30 years. And then you hit perimenopause and you've done nothing to rehab it. And so now you're having to take care of 30 years of dysfunction instead of let's fix it like in the year or two after you have the baby. Then you know how to maintain it, you know what to do, and you know, because a good pelvic floor therapist is going to tell you, okay, you know, we're done for now, you've met all your goals, you're doing everything you want to be doing, but these are the signs that you need to come back in, right? So that, or like when you're, so like I'll always talk to my clients that have prolapse, for example, about like, okay, if the prolapse worsens at some point and pelvic floor therapy isn't working anymore, like the pessary is an option. So we want to get you one of those as soon as possible because that could prevent it from getting worse. And unfortunately, in the US, they don't really think of pessaries as preventative. There's not there's not a lot of research on it yet, but they're starting to do some research in the UK. And the preliminary, like the early results of the studies are that wearing a pessary like early on, like postpartum.
What is that?
So a pessary is like a silicone device. It's usually a ring. Sometimes it's a disc. And then there's other shapes as well for like more different types of prolapses. But it's basically, I call it a back brace for your vagina. It's a silicone device that it sits on top of your pelvic floor and it supports the vaginal walls. It supports the bladder and the urethra so that the pressure of gravity, right, downward isn't so hard on the vaginal walls. And that way, you know, the theory would be that, well, if we relieve the pressure in the early postpartum period, will the tissue heal better? And will the person be able to get stronger, right? Because everyone's the fear with it is that people say, well, is that going to make me weaker to wear it? Not if you're doing your pelvic floor exercises and you're going to the gym and you're loading it and you're doing all the things to get stronger. Like if you just let it sit there, it's going to get weaker no matter what you do, right? Pessary or no pessary. But they're starting to come out with some studies out of the UK that show that wearing the pessary for 2 years in the earlier postpartum phase, after 2 years of consistent wear, these women showed a reduced prolapse grade. So their prolapse actually got better. Their pelvic floor was not weaker. Like they were, by all the tests and measures, better than they were when they started. So some of that is going to be time and like a natural healing process, but what's the downside of like supporting tissue that's under a lot of strain? And especially if you're someone that has multiple kids, they send you home and say, don't lift more than 15 pounds. You're like, well, I have a 2-year-old, a 4-year-old, and a 6-year-old. So that is a pie in the sky pipe dream, right? Like I will be lifting 30 pounds next week, right? So to have some support with that. So that's what pessary is. So like we'll educate people on like, hey, there's this thing out there. So if your symptoms are getting worse, like when you go to the urogyne, and we'll refer people to their urogyne sometime during therapy if we think this is a good idea for them. But we want them to have it already in their back pocket because not all urogynes are very like pro-conservative care. Some are, but others, the first they're going to tell you is surgery. You're a great candidate for this surgery that I'm really good at, right? So pessaries aren't always offered, and especially less so in the US. So we just want people to know that they have those options and like, hey, yeah, get it sooner than later. Even if your doctor says, oh, well, we'll just wait and see what happens when you're 50 or 60.
Right.
Say, no, I would actually like to have it now so that I can be wearing it for the next 20 years and maybe it will help me not get worse.
Yeah.
So question about that.
Yeah.
So once you have a pessary, is it something that you live with forever, or is it something that the muscle heals, your prolapse diminishes? Is it something that's removed later on?
So is it something that will cause the muscles to heal and the prolapse to diminish? We don't know.
No. Okay.
They're just starting to research it.
Okay.
So I couldn't make a definitive statement on that. And it's going to depend, like, how bad is the prolapse?
Right.
A grade 1 prolapse, there's like barely any movement.
Okay.
That might never cause anyone any symptoms anyway.
Right.
A grade 4, it's like entirely outside your vagina. Like, I don't think wearing a pessary is going to fix that, right? So it probably depends. It's probably going to be different for the different grades and types of prolapses. And we just don't know. We just don't have enough research.
But does it stay in?
So it depends on the type of pessary.
Okay.
The discs and the rings, usually the urogyne will teach you how to put it in and out yourself.
Okay.
So they have to be taken out every so often to be cleaned,
Right.
right? So they'll instruct you when you get the device, like, hey, you need to clean this every 4 months or every 6 months. But you can take it in and out yourself. So some people just like to wear it when they exercise. Like if they're runners and they're like, I'm just wearing this preventatively. I feel better when I run with it in. So they'll just put it in to run and then they'll take it out. Some people like to wear it all the time, but then they like to take it out for intimacy. A lot of people don't even notice it with intimacy, so they don't take it out. So it just depends. Now that's the discs and the rings.
Right.
The cubes, which are more like space occupying, and then there's some other funky shapes that they have, those rely a little bit more on vacuum suction to stay in, and so they're trickier to get out. So sometimes it depends on you and like how good you can be at like the dexterity of like releasing the seal and getting it out safely.
Oh, wow.
So I've had like older clients where they prefer not to do it themselves. They would rather go into the office and like have the nurse take it out and clean it and put it back in.
Okay.
But there are options. Yeah, and
I
it
feel
depends
like
on the type.
menstrual cups are like getting really popular. That's what I'm picturing.
They're just much
like that.
beefier. Yeah, so it's
like-
a similar shape. They're just
Yeah.
like, they're much bulkier. And they have different sizes. So when you go to the urogyne to get one, there's like, they'll start you with like the most common couple sizes. They'll obviously do a pelvic exam and they'll say, okay, this is what I think you need.
Mhm.
But then usually they send you home with it to trial. And if it's not working, if it's uncomfortable, if you're getting any kind of discomfort or if it's falling out,
Yeah.
then you're supposed to go back and try a different size. So again, like there's a variety of urogynes out there where some of them are awesome and they'll go through 10, 12 different pessaries with you and they will find the one that works.
Yeah.
And then there's other urogynes, this is probably more common with just straight up gynecologists that don't actually specialize in it, but they'll try the first few most common types. And then they'll be like, well, this just isn't working for you. Like, let's look at our surgical options again. Or let's like see, or I can't, there's nothing else I can do.
Mhm.
So you want to find that doctor that is gonna like, well, we haven't tried this one yet. Like, let's try this one and see how that goes. Yeah.
And
Yeah.
this is part of the conversation. Just letting women know what options are out
Right.
there, and not just to go with the first, oh, no, it's okay, let's wait on that, when we could be doing something now.
Yeah.
To prevent, problems later
Yes.
down the road.
Yes. And I mean, that's a huge one. It breaks my heart when I have a patient tell me like, oh yeah, the doctor said we'll just watch and wait and
Yeah.
see if it gets worse. I'm like, but there's so much we can do
Yeah.
to help it not get worse.
Totally.
Yeah.
Another question with regards to when you were talking about one of the major reasons when someone has incontinence and they end up in, like, say, a nursing home, and then they can end up their lives cut short because of it. Is there ever a point in a woman's life where it's just too far gone, pelvic floor PT is just not gonna help, whatever? Is there such a time?
For some
in
women,
this-
yeah. Because there can be types of injuries, there can be things that happen
Okay.
where the structural system is
Can't
just,
support.
it can't support it,
Okay.
right? So those would be the people where like, yeah, you should get your surgical options. Like you should go interview your surgeons and get it fixed,
Yeah.
right? Because we can't fix everything. I mean, there are things that we can't fix conservatively. Just like with knee arthritis or anything else. Like
Right.
I can treat someone's knee arthritis for decades.
Right.
And they can feel great and they can come in periodically and like we can help them feel better, help them be active, get it moving. But at some point, it's going to be bone on bone.
Yeah.
And there is nothing that I can do to change that. And that's when it's like time for the knee replacement, right? This is the best thing for you,
Right.
is to get this replaced before you get so old that the recovery is going to be much harder, right? So there's always like a sweet spot. And I have this conversation treating pelvic floor. I think I have this conversation the most with women regarding hip arthritis.
Yes.
Because if you have really severe hip arthritis, like a hip replacement is not a hard recovery. Like generally they go really well and people feel great afterwards.
Right.
So it's like, okay, if your hip is like shredded and you're not able to exercise, you're not able to even like walk your dog for an hour, you can't pick up your grandkids, you're like creaking when you get out of your dining chair every single night. Like you're miserable and you can't do the things that you know you need to do to stay healthy and happy.
Right.
Just get the surgery, right? Like it's time. You don't be scared. Like I've rehabbed so many of these. The recovery is going to be smooth. Just get yourself a good surgeon, get it done, and like we'll see you on the other side. You know, so there's a time for surgery for sure. And there's things that happen systemically too with like bladder and bowel where like medication is appropriate. Like there's things that we can't fix. And so that's where it's really important, like for us as pelvic floor PTs, that we know like, hey, this isn't responding the way I want it to. I would like you to go see this urologist, or I would like you to go see this GI specialist. You know, so it's our job too to recognize when what we're doing isn't working. There's something that's not adding up and we need to refer out.
Okay.
But I mean, if it was just you dealing with it on your own for 30 years, you would never know that like, hey, maybe I should go get my thyroid checked, right? Or like, so things like that. So we can help to kind of, when you need to see a doctor, we can help you get that to happen also. Yeah.
Any questions, ladies?
Hey, that's good because, you know, now at my age, 53 this year,
Yay!
I don't know about that, but hey, it is what it is. You know? But my doctor's like, oh, let's do all this testing at the beginning of the year so you meet your deductibles. And I'm like, oh, I never thought about that. You know, she's like, and then we'll do all this stuff, you know, this stuff. And I'm like, what kind of stuff are you talking
Yeah.
about?
Do I need all this stuff that you're planning to do?
Yeah. So anyway, it's good though to pay attention because that's what my doctor reminds me every visit, you know, through the mandatory annual. She's like, you know, you need to check your body from head to toe.
Yeah.
And now I see why she said that.
Yeah.
You know.
And things just start to change a lot more rapidly.
Yeah.
I think like in your mid 40s, typically for most people, they start to notice the changes. I mean, I know I have the last couple of years. You just start to notice the changes more rapidly.
Right.
Because things are starting to escalate and your hormones are starting to change a lot more rapidly at that point. So, but yeah, I think, you know, I'm a big believer that just like your dentist or your PCP, a physical therapist is not a bad person to see every year because we're going to pick up like, okay, let me look at your shoulder range of motion. Okay, compared to last time I saw you, your right arm is only going half as far as your left arm. Well, it doesn't hurt. Well, let's see if you can take it all the way up. Oh yeah, now it hurts, right? So like we'll screen things like that you maybe you're just kind of subconsciously avoiding it. But then we're like, but yeah, that's like not good, right? So let's fix that before it becomes a rotator cuff tear, right? Knees all the time, right? And hips, like, my mom has had both hips replaced and, you know, it's a gradually your hip will tighten up. And so you're like, well, I can't do quite the same poses in that yoga class. I can't quite go as deep on the reformer. Like I can't quite do what, but I'm just getting older and whatever. And before you know it, like now I'm climbing stairs and my hip is killing me. And like, it just happens little by little where then all of a sudden you realize like, I'm not doing all this stuff because my hip hurts and I'm just expecting it to fix itself. Then you finally go to the therapist and you have like no rotation. And then it takes us a long time. Whereas if we had caught that like early on before it started hurting, you know, you wouldn't have had to stop doing all those activities. So shoulders and hips and knees and like certainly pelvic floor, like we talked about, just a proactive check of like, you know, you're 6 months postpartum and you have like maybe it's a grade 2 prolapse. It's not that bad. We're not super worried about it, but this is the things that you need to be mindful of to have it not get worse.
Right.
And this is how you, okay, now we're training you to do your pelvic floor contractions correctly. We talk you through, like, this is when you should do them in your workouts, and this is the right amount to do so that you can do the best you can to help this thing not get worse later. Yeah, but I think, because PTs, when you go to see your PCP, I don't see mine that frequently. I don't even have one right now. But generally, they're not doing like a movement strain, right? They're not like saying like, hey, do a deep squat. Okay, now show me like single leg balance on one leg. Now show me like, can you reach up high? Okay, how much weight can you lift, right? So they're not checking the musculoskeletal system very thoroughly. So from that aspect of like us not wanting our bodies to hurt, I think a physical therapist screening is like, honestly, would be so awesome if people got that as part of their standard annual.
Is it something that's like covered through your insurance?
I mean,
really bad. I
for
pay it
your
every
insurance,
month.
it's going to depend on your insurance, but for insurance to cover something, they want something to be wrong.
Right, so
Insurance
you have to
doesn't
have
like preventative care.
analyzed by your doctor.
So, but, I mean, can you think of anything in your body that's hurt in the last month? You don't have to tell me what it was, just a yes or no. Anything in your body that's hurt, then you have a reason to see a physical therapist. Right? So, and we have direct access in California, so you don't have to have a doctor's prescription. Now, if you have an HMO or managed care plan, that's what a managed care plan is. They want to manage your care. So they tell you when you get to go. If you have anything that's not a managed care plan, so anything that's a PPO, you can go to a specialist whenever you want. So you could come see me at my office without a prescription for sure. And like Anthem Blue Cross PPO, they're going to cover that the same as they would cover. And all you have to do is say, well, yeah, my elbow was hurting last week.
Right.
That's your reason for coming to therapy. We do the evaluation on your elbow. We look at your whole body because we treat the whole body as a system. And, and then you go from there. And then if we have any pain point that we need to treat, now at my clinic, we've chosen not to be slaves to insurance. So we don't care if they think you need therapy or not. We're still gonna see you, right? And we don't care if they think that your knee is not related to your elbow pain. Like we're still gonna treat your knee, right? So whereas if you go to a clinic that's like insurance is their payer, like that's where they get paid versus you're the payer, then you're subject to what the insurance company thinks you should have. So that's the big difference between like, and I think with pelvic floor it stands out even more than with other maybe specialties, because I hear all the stories maybe. But yeah, it's like one of the big complaints is like, well, we only have one body part on the thing, so like we can't treat, like I have your prescription for your shoulder, so I really can't look at your hip, like we have to get the prescription and the referral, and like they might not pay. So it's just a whole bunch of shenanigans that like if I really want to look at you as a whole person and have you feel better, like it's just too much paperwork and too much of pleasing somebody besides you. So that's why we've decided to do it that way. But you can still submit to insurance. If you have PPO, you just send in the super bill, and then they're going to cover you how they're going to cover you.
Right.
Go ahead.
So I have Kaiser.
Yeah.
So if I'm looking for someone who would be your counterpart at Kaiser, what would I ask for?
Pelvic floor therapy.
Okay.
Yeah, Kaiser has it. For sure. They do. I actually worked for Kaiser for about 6 months. I started my company right before I got pregnant. So I quit my job and started my company, and then I had a baby. So after I had the baby, I was building my business back up. And so I worked for Kaiser per diem while I was doing that. And it is that frustration of well, this person is telling me that their foot and their knee hurt, but now Kaiser's well, you have to go see the orthopedic therapist for that. So I'm I can't treat that. I can only treat this, which irritated me to no end. But yeah, you just would tell your GYN that you want to go to pelvic therapy and tell her why, and I can't imagine that she wouldn't write you a referral.
Okay.
And then you just have to wait, because the wait times at Kaiser are usually about 6 months.
Yep.
And then they're going to see you about every 6 weeks. Whereas when I see someone, I usually want to see them every week to start till we get rolling, right? And then as you're independent with your stuff, then we're going to reduce frequency until you don't need us anymore. But it's just hard sometimes, and especially if you don't have any symptoms, then that's probably fine, right? If it's not urgent, it's not an acute issue, and you've got time and you're not in pain or anything, then seeing someone every 6 weeks may be a totally fine option. But if you are in a lot of pain, you want it to be better now, and you have to wait 3 months for the first appointment, and then you can't get on the schedule for another 2 months. Like, that's frustrating.
So a question that I have is, if I were to go outside Kaiser and come see you,
They won't cover it.
no, I understand that.
Yeah.
But what do you charge?
Oh, I charge, so our clinic, our eval is $255, and then our follow-ups are $195. And that's an hour with a therapist.
Okay, so, but you wanna see someone every week?
Usually to start.
For how long?
It depends on the patient.
Oh, okay.
Yeah, so again, like if you don't really have a lot of symptoms, it's more of a preventative care thing, we might not even start at weekly. It might be like, hey, here's what I want you to think about for the next 3 weeks. Let's meet in 3 weeks, and then we'll revise and update, and you might not even need that many visits if it's preventative care, right? If you've got something going on, like let's say you've got a lot of pelvic floor spasm that we need to work through, and you need like manual therapy for that. Plus, we want to work on your breath mechanics and your posture and your inter-abdominal pressure management. You're trying to work out with Michelle and your hips bothering you a little bit. We want to address that at the same time. Well, then I want to see you every week, probably for 6 weeks or so. And then we would look at that and say, okay, now can we reduce frequency a little bit? But yeah, we can't tell. I can't tell you how long or how frequently until I would assess you and know what the problem is, right? I laughed about this. I had an evaluation actually the other day, and she asked me that question before. It was like in the first 10 minutes of our chat, and she's like, "So how many visits is this going to take?" And I'm like, I haven't even looked at you yet. Like, all we've done is talk about your birth. Like, I know nothing about your body. Like, I can't tell you that. She's like, okay, yeah, I get it. And I was like, can I just at least do the assessment first, and then I'll tell you. And then I told her, like, okay, I really think with everything that we found, we should do weekly for 6 to 8 weeks. We might not need the 8, but let's book the 8 so that you don't have to sit on the wait list. And then at that point, I think we probably will reduce frequency. I can always be wrong. Like, we might find that she doesn't need that frequency for that long, or we might find that she needs that frequency for longer. Like, I don't have a magic 8 ball. You know, I can just make my best guess of like, hey, this is how you're going to get better the fastest. And then it's up to you to decide, like, okay, can I do that? And if I can't do that, like, what can I do? And then we work around that, because like, you don't work for me. It's the other way around, right? So if you decide you can only come in every month, I'll see you every month, right? Like, and I'll be honest with you, like, we might not make progress as fast, right? You're gonna have to be really good with your home program, because if you don't do your home program for that month,
Yeah, it sets you back.
it sets us back, right? So we just make our best recommendation on how do we think you're gonna get better the fastest? And then it's up to you to, do with that information what you want. Does that help?
Oh, yeah, a lot.
Yeah. Any other questions? I talk a lot.
Yeah, so do I. I talk all
I'm
day.
learning
So.
so much about myself.
So what should a woman look for in terms of even picking a good
Yeah.
floor therapist? I'm assuming, she's got a little list in her head, at least when she's walking in.
Yeah.
She's got this going on, I'm
Yep.
like, yeah.
Yep. So I always tell people, like, if someone can't come and see us for whatever reason, then I say, okay, when you call these places that your insurance company is giving you or whatever, first you want to ask, like, is the person that you're putting me with, like, do they do internal exams?
Right. Yeah.
Because if they don't do internal exams, this is not someone you want to be seeing for your pelvic floor,
No.
right? So that's the first question, because I have had clients come to us where they're like, yeah, they sent me this place and I went there and they didn't do it, and they said they didn't know how to do it. So you definitely want to ask, okay, simple questions like, okay, how long has this person been treating pelvic floor, right? Because that matters. Like, did they just take the class 2 weeks ago?
Yeah.
That might not be the person that you want to see if it's your first choice, right? So how long have they been doing it? A kind of question that you could ask, and I don't know how they'd always answer this, is what percentage of this person's patients are pelvic floor patients?
Right.
Because if they're an orthopedic therapist, but they're just seeing the pelvic patients that wander in, they might be seeing 3 pelvic patients a month.
Mm-hmm.
So that even if they've been doing it for 5 years, they might not have that much experience, right, in it. So if you look at the company's website too, if it's a company that has like the profiles for the therapists on the website, those of us that are passionate about this, like you can probably tell from me, like we are passionate about it. So they are gonna have it in their profile, right? They are gonna have in that bio, like, I've taken these courses, I love treating this population, pelvic floor is my, it's gonna be in their bio.
Yeah.
If they don't even mention it, like, I would be maybe a little bit concerned, but yeah. So you would want to ask like, okay, how long have they been doing it? What percentage of patients that they see are pelvic floor versus something else? Do they do internal? I would potentially ask like, how much time do I get to actually see the therapist for? Because at a lot of the insurance-based clinics, you're going to see the physical therapist for 15 to 30 minutes, and then you're going to be passed off to an aide. And you're going to do exercises with the aide for the rest of your time. So the aide is not only not a physical therapist, but they're not a pelvic floor physical therapist for sure, right? So this is one of the reasons I left my original job, because like I said, they were great. And then for an orthopedic clinic, like our aides were great. But for me to hand a pelvic floor patient where I wanted to cue them to contract or relax their pelvic floor with every movement, and I wanted to make sure their pelvis like wasn't moving at all into the mechanics I didn't want, I'm not gonna trust some 20-year-old kid that hasn't been to PT school. And like our aides were mostly guys.
Right.
Nobody wants to be told they're going to contract their pelvic floor by a guy, right? Like I don't, at least, like out in the middle of a big gym, right? So it just wasn't the most comfortable setting, right? So you might also ask like, okay, in my typical session, am I gonna see the physical therapist for how long? Like how long do I actually have one-on-one with the therapist? So that's another good question. It'll just give you a sense of what to expect. And some insurance-based clinics are seeing them for like maybe 40, 45 minutes. I don't know of any that do an hour, except maybe Kaiser. I'm trying to remember. I think we had an hour for evals and maybe 45 for follow-ups at Kaiser. It's a little bit better.
If I get in touch with you outside of this, do you have a recommendation
For a therapist at Kaiser, I don't know who's there anymore.
Oh, okay.
I imagine some of the girls I knew back then, so Sarah Madigan was there when I was there. I know Nikki's not there anymore. I don't know. I'd probably have to go look at their website and see who's treating and be like, I knew them and I knew them. But you know, there could be other great therapists there now. I don't know. It's been 10 years since I worked there. Yeah, so I'm sorry, I got off track. Okay, so things to look for when you call or when you go in. Oh, so like in a standard ortho clinic, you're gonna have, most patients are gonna be like out in an open gym, right? They might have like a couple private treatment rooms where you might start in your eval, but then a lot of your exercise is gonna be done out in a big open gym with a mixed audience, right?
Oh, I see that a lot.
Yes. So that's one of the things people worry about when they're going to come in and see us and they don't know what to expect. And I'm like, well, we do all pelvic floor. I mean, we treat the whole body, but we're focused on pelvic floor. So all my therapists are in a private treatment room. Like the majority of your session is probably in a private treatment room. We do have a gym that we could go into. You've seen our space, right? You haven't seen it yet? Oh my gosh, I can't believe this. So we do have a gym that we'll take you into if we want to do like a barbell, or we have a reformer in there, we have a treadmill in there, so if we want to watch you run, like we'll put you on the treadmill. But by and large, we're one-on-one with you in a private room, and it's for the whole hour. Like we don't have aides. I can't say I don't have aides anymore. I did hire an aide, but she doesn't do any patient care. She holds people's babies, and she does answer the phone, and she greets patients, and she does office stuff. We don't have anyone besides physical therapists that's like doing direct care with the client. Yeah, so that's another thing you can ask, like how long am I going to be with the PT? Am I going to work with an aide? Another thing you can ask, which I mean, I don't think this is, I'm not even going to say it because I don't think it's important.
Now you gotta say it. Look at me, I'm like, now you gotta tell us.
Okay, so has anybody heard of biofeedback?
Yeah.
Mm-hmm.
Has anybody heard of like the LV, or like there's these muscle trainers you can get? Okay, so biofeedback has been around for a really long time. And it's something that pelvic floor therapists will use to get like a muscle reading from the pelvic floor muscles. So there's like an electrical output of your muscle when you contract it. So we'll use either a surface electrode on your skin right by the anus, or we'll use a vaginal electrode which goes inside, and that will pick up electrical activity from your muscle when you contract. So like if we want to know if you're actually turning your muscle on or off, for me, I just like to palpate with my finger, but like, let's say your contraction isn't showing up on the finger. I'm like, okay, well, I want to see if you're actually getting contraction. Let's try the biofeedback. So biofeedback is great, and it certainly has purposes. But for example, before I started my practice, I interviewed with Sharp, and they have like a whole biofeedback clinic where there's no therapy involved. You just go in and a nurse sets you up on the biofeedback, and you sit there for 20 minutes and do your pelvic floor contractions with the biofeedback, and then you leave. That is not pelvic floor
I was
therapy.
about to say, that's kind of weird.
It's not pelvic floor therapy. And why would you do it at Sharp when you could just go buy an LV and do it while you watch TV? No, right? So to me it sounds terrible, but that's like, so if you are going to a therapist where half the treatment is you sitting on a machine,
Yeah.
that's not quality therapy, in my opinion. I'm not saying that these machines aren't helpful. They can be very helpful. But if that's most of what you're doing in therapy, like, that's not, that I would say that that's not a great quality of care. And if you are doing it, the physical therapist, if it's biofeedback, should be like with you while you're doing it, right? And working with like, okay, how can we get a better contraction? Now you see this here, okay, this means that your pelvic floor is turning off a little bit too soon, so your endurance isn't great. So let's see if we can hold that for a little bit longer, right? So they're using it as a tool versus saying, hey, you go do this by yourself while I work with somebody else, and we're just gonna bill your insurance for this.
Wow.
So be wary of biofeedback. It's good, it's useful, it's not a bad thing, but it shouldn't be like the bulk of your treatment. I'm trying to think of does anybody have any other any other specific things they think I'll see what else to ask. I mean, those are big ones. How long do I get to see the therapist? How experienced are they? What is my treatment going to involve? And we have people ask that, probably because we're cash. You know, people want to know, like, what are you going to do? What are we going to do? What am I paying for, right? So I'm very used to explaining that, you know, that whole body approach. And I don't know if you call the front desk of an insurance-based clinic, I don't know that they would be able to answer that question. That's the hard thing, right? So, like, if you call the front desk and you say, well, does the physical therapist take a whole body approach? Are they going to, like, look at my breathing? Like, the front desk has no idea. So you then, at that point, you kind of just have to go and feel it out, right? So I had a client what's that?
Ma'am, please hold on.
Yeah. So I had this client this last week where she told me a story about the therapist that she saw at a hospital, and she's like, yeah, I saw her twice, and I just knew she didn't know what she was doing.
Wow.
And then she told me, and I said, well, actually, you know, I agree with her on this, and I agree. So the therapist wasn't terrible.
Okay.
But this client, she just knew. She knew by the second visit that she wasn't going to be able to get what she needed from that person.
Okay.
And so that's why she sought out somebody else, right? So I think that you can do that, right? I mean, you can go and see what you can get covered under your insurance, and like, because there are some great therapists working at insurance-based clinics. It's just you want to know, like, at what point do I say, this is not giving me what I need, and you try something else.
I think that's important to let people know though too, because I feel like if the doctor says that, then we just listen. And I feel like not many people know that, like, you don't have to just go with that doctor. You can go somewhere else.
If you're not in
Like, trust your gut. Just because, you know, it's not like, if that's kind of not the answer you want, you can literally go somewhere else.
Yeah, get a second opinion.
Yeah.
Yeah, second opinion is never a bad thing.
Yeah.
Never a bad thing. I mean, I get second opinions from the other therapists in my office.
Yeah.
Like, I feel very blessed that, like, I have 8 now, right? Because when it was just me,
Yeah.
you know?
Yeah.
But now I have, like, 7 other therapists that I can say, like, hey, I'm stuck with this patient. Like, what do you think? Can I have them see you for a couple visits?
Good to brainstorm with
It
them.
Yes.
Yeah, definitely.
Yeah. Other questions? Think of specific
No, that was a lot.
questions?
That's
Like, how are we on time? Because I have, like, some active things we can do.
Oh, we love active.
I mean, I'm not going to make anyone jump up and down. These are, like, very, like, breath work kind of things. I didn't come in my workout clothes, as we already discussed. So, but yeah, I love to kind of have people walk through, like, a posture and diaphragmatic breathing and, like, can you feel your pelvic floor and, like, some different cues. Do you guys want to do that?
Sure.
Yay. Okay. So I was going to start, I just realized, like, I was going to start to tell you guys about the posture stuff, and then I dropped the pelvis and we changed topics. So we were talking kind of about the pressure, right? So posture is important for lots of things, but it's very much important for your pelvic floor because your pelvic floor is sitting at the bottom, right, of, like, your whole system. So it's carrying a lot of weight. And how you carry it impacts how much work the pelvic floor has to do. So when we have a neutral posture, or a neutral pelvis, I should say, your ASIS, or your front hip bone, if you, like, palpate your front hip bone there, and your pubic symphysis, which is the lowest bone you can feel, they should be in line in a neutral pelvis. So it looks really anteriorly tipped, right? It looks like it's super tipped forward, but that's like a neutral pelvis. So that gives you this nice lumbar curve that we are supposed to have. So the curves in our spine are there to help us absorb shock and to distribute weight the way that it needs to be to go down through your feet. So we need those curves. When we don't have those curves, we have fallout in our discs, in our nerves, in our joints themselves, and we end up with pain, right? So we want those curves. So when the pelvis is anteriorly tipped like this, we are set up to have that nice normal lumbar and thoracic curve. But I digress. So when you have the pelvis anteriorly tipped like this, you can also see that the bladder is then resting like largely on the pubic bone, right? So it's like well supported, and then the uterus is tipped forward on top of the bladder for most of us. Some people have a retrograde uterus, but we don't need to go into that.
Or we don't have them.
Or you don't have one, but you still have a vaginal vault. So one of the things that will happen after hysterectomy is vaginal vault prolapse. So we still want your vaginal vault to be well supported, right? So this just does not want to stay. Okay, so bladder and organs stacking up on top of it. When you're in this nice neutral position, you have good bony support. When we do what we call bum tuck and slouch, that bone kind of slides out from underneath your organs. And now everything's just resting on the muscles. Does that make sense? So here our muscles have a lot of help from a bone, and they're oriented more vertically. So when they contract, they're not working as much against gravity as when we tip here. And now not only are our organs not supported by our bone as much, but now gravity's going like straight down on these muscles instead of at an angle. Does that make sense? So it's just making it harder for the pelvic floor to do its job. So purely from the pelvic floor standpoint, a posterior tilt is gonna cause some issues. It tends to make the pelvic floor tighter. And there's a couple arguments. Some people say, well, it's because like the coccyx, which a lot of the muscles attached to, is now kind of tucked under. And so the pelvic floor is in a more shortened position. I don't know if I buy that anatomically speaking, but I will buy that when you tuck under and now there's more pressure on the pelvic floor, well, the pelvic floor's job is to keep things from coming out of you, right? So if all of a sudden it has more pressure on it, what is it gonna do? It's gonna tighten because it doesn't want things to fall out of you. So it's gonna grip, right? So when we're in this bum tuck all the time, our pelvic floor is fighting the pressure, and so it's gonna be more prone to be tense and tight, right? So we wanna be in this nice neutral posture. Now what can also happen with that, if we're in that tucked and the pelvic floor is kind of a little bit more tense, it's gonna be harder for us to feel a contraction because it's already a little bit tense. And it's also potentially going to be harder for us to let go. So if we want to be able to a nice full excursion contraction where we're lengthening and shortening, we want it to be in like a nice close to optimal place in relation to like gravity and the bones, okay? So there's a lot of other reasons why a neutral pelvis and a neutral spine are helpful, especially like for spinal health and things like that. But let's start with finding a neutral pelvis. So we'll do it in sitting first because it takes your hip flexors and your hamstrings out of the picture. Almost nobody has normal hip flexors and hamstrings, right? So sit up tall and just kind of like sense, well, even don't sit up tall, sense like, is your weight on your sit bones or is your weight on your tailbone, right? So your sit bones are these bones right here. We call them your ischial tuberosities. They're the two big bony ones you feel. So when you're in a neutral pelvis in sitting, you should feel that your weight is going down through those sit bones versus if we're kind of getting tired and we're leaning back on our chair and we're just at rest, now the weight is going to be more down on the tailbone, right? So then we're in a posterior pelvic tilt. In a neutral, we're going to be up on the sit bones. And a lot of people do also have, an excessive anterior tilt, which is where you'd have like a sway back kind of situation, we call that excess lordosis. Okay, so we have this nice neutral position. So you can also feel, apart from where your weight is on your sit bones or tailbone, if you feel, I think we already did this, feel your ASIS, which is the bone in the front of the hip. And then if you find your pubic bone, I can hardly do it in these pants, but pubic bone, which is like the lowest down bone that you can find on the front. So, and then just kind of check and see, like, are those two bones lined up? Or if the pubic bone's out in front, I'm posteriorly tilted. If the pubic bone is way in back, then I'm anteriorly tilted.
What do
Right.
you mean by lined up?
Like in a vertical plane.
Okay.
So if you were to put your pelvis against a wall, both of those bony points would be touching the wall.
Okay.
Yeah, so they're lined up. It doesn't have to be perfect, right? But if you find like, you're like, oh wow, my pubic bone's like 2 inches in front of my, right? Let's try to bring it a little bit closer. So sometimes, especially when we hit a certain age, we have disc degeneration, we have spinal things going on, like your back may not want to be in that neutral position. And so you might have to modify it a little bit, right? But that's where in therapy, then we're saying, okay, well now we have to make sure you have the back mobility to get in the position I'm telling you that's going to be better for your pelvic floor, right? So again, like your whole body is a system, like it doesn't live in isolation. So neutral pelvis. Okay, now let's look at your ribs. So ribs, does anyone know what muscle attaches to your ribs? You're not allowed to
I'm not
answer.
allowed to answer, okay.
It's a really important one. You would literally die without it. Your diaphragm. Okay, so your diaphragm attaches inside to the inside of your ribs. Your diaphragm controls your breath, right? Which is why without your diaphragm, you would die. Because your diaphragm, when it contracts, your diaphragm goes down and out. That is what opens up your lungs to create a negative pressure to pull air in, right? So your diaphragm drives down and out on inhale. That's to pull air in. And then on exhale, your diaphragm rebounds up and in. So with the movement of your diaphragm, your ribs are going to move, right? So on inhale, your ribs are going to go out. On exhale, your ribs are going to rebound in, okay? We talked a little bit about like the diaphragm and the pelvic floor are in the same system for pressure management, right? So your diaphragm is up here. When you inhale, it goes down. So what does that do to your organs if the pelvic floor doesn't move? Squeezes them, right? And they don't like that. So your brain says, hey, pelvic floor, lengthen a little bit. Let's keep the pressure the same, right? So when your diaphragm goes down, your pelvic floor is naturally going to lengthen. So are your abdominals for the same reason. Because if you keep them pulled in really tight and your diaphragm is going down, either your pelvic floor has to go down a lot more or we're going to squeeze the organs, right? So pelvic floor gets out of the way, abdominals get out of the way a little bit. So everything's lengthening on inhale. Then on exhale, the diaphragm is rebounding up and in, the rib cage is going to close, the abdominal wall is going to come in, and the pelvic floor is going to lift back up a little bit. So this is a tiny little movement that happens literally every time we breathe. If that movement pattern gets jacked up and we forget how to do it, that can cause a lot of problems with leakage because the pelvic floor is not responding to what the diaphragm is doing and the abs are doing, and nobody's like playing well together. You're going to have leakage. So diaphragm goes down, pelvic floor goes down. Hands are on your rib cage. So we want the diaphragm for a good diaphragmatic breath. The ribs are going to be expanding 360 degrees. Has anybody heard the term like umbrella breath or 360 breath? So we want movement in all directions. So we want a little bit of front movement, a little bit of side movement, and even a little bit of movement to the back. So if you wrap your thumbs around the back and kind of like take your breath in and do a nice deep one. And see if you can feel movement in all directions. And then let the breath out. And you feel the ribs kind of close. So this breath, we're going to pay attention to what the abs are doing. So as you inhale, are my abs lengthening or am I pulling them in? Right? Self-assess. You're not going to assess me. Okay? So let that breath out. And on this next breath, see, can I let my abs lengthen as I inhale? That was better. Good. And then as you exhale, to just naturally rebound back in. Okay. Who feels like good motion in their ribs? You feel like your ribs are moving pretty well? Of course you do. Better.
I mean, I think I do.
I think I do. I think I can. Who feels not much motion in their ribs? So sometimes we'll see like not much motion in the ribs and a lot of motion in the belly.
Yeah.
And sometimes we'll see no motion in the belly, right? And no motion in the ribs. And that's where then we're concerned as pelvic floor therapists. And sometimes we'll see a lot of motion in the ribs and no motion in the belly, right? But this just tells us, so when we assess your breathing, we're not just doing nothing, right? We're seeing like how is your body managing this relationship, right? And is there dysfunction going on with the way your diaphragm and your abs are working, even with just quiet breathing, that might be impacting your pelvic floor, right? So when your pelvic floor, we can't put a hand on our pelvic floor. I mean, you can try if you want to, but typically the pelvic floor and the lower third of your transverse abdominis, your transverse abdominis is like the deepest layer of your abdominals. It's like a corset, it wraps around you. So its primary motion is compression. It compresses the abdomen, okay? So when your lower third of your transverse abdominis fires, your pelvic floor usually fires with it, if it's functioning normally. So we can put a hand on the lower belly, and if your system functions normally, that will tell us something about what your pelvic floor is doing. Okay, so before I throw pelvic floor in here, let's try that. So we're gonna have one hand on the ribs, one hand on the belly. Take your breath in, think about opening the ribs into the hand in all directions, keep your shoulders relaxed. Let your belly drop into your hand. Then as you exhale, just exhale, but you should feel the belly kind of naturally come back in. So try a few of those. Inhale, and then as you exhale, is everybody feeling a good belly motion there?
I think so.
Good, good. Kind of, she's not
moving out.
she's not buying it. How about yours?
Not really.
Not moving. So I'm concerned with your posture a little bit because you're so high. Because being higher is going to put you into a little bit more potentially of wanting to pelvic tilt forward, but I don't have my hands on you, so you can tell me if you think you are doing that or not. Do you feel like you're pretty anteriorly tilted? Or is it just your sit bones hurt? Do your sit bones hurt?
No, I have sciatica and all that kind of problems, so
Yeah.
it's very uncomfortable for me to sit in this position at all.
You can stand up if you want.
Okay.
You don't have to sit.
Okay.
Are you better in standing?
Yeah.
Yeah, great. Then let's have you stand then. Okay, so you can do the same thing in standing, right? With your pubic bone and your ASIS.
I feel like my belly's not moving.
Okay. Okay, so next we're gonna combine the pelvic floor. So what I want you to think about when you try for the pelvic floor contraction, I'm gonna have you imagine that there is a red kidney vein at the opening of your urethra, right where the pee comes out. When we contract, we're gonna close the urethra around the kidney bean. You're gonna imagine this in your head. You're gonna visualize it. And then you're gonna lift the kidney bean up like a centimeter, okay? Then when you inhale, you're gonna drop the bean on the floor, okay?
I'm not quite getting this.
It's okay.
I don't know about anybody else.
You know, I am cramming like an entire therapy session into like 15 minutes, so there's that. It's just a tester.
Okay.
All right, so when you inhale, you're gonna open your ribs, let your belly drop into your hand. Now you're gonna exhale, close the urethra around the kidney bean, lift the kidney bean up, and inhale and drop the bean on the floor. Okay, so if I'm talking too slow for you, try at your own pace a couple times, okay? So inhale, let the belly drop into your hand. Exhale, close around the kidney bean and lift the bean. Inhale, drop the bean onto the chair or onto the floor.
A lot of work.
It's a lot of work.
Yeah.
So let me ask you this. Do you feel your belly moving?
I feel my belly
Do you-
moving, and I also feel.
And you feel that? Great. So that's exactly what I would want, right? So
It's
if you
like a
can...
lot of. I
It's
have
a
to
lot.
think about it.
Yeah.
I'm like, oh, no,
Well,
don't
no one's probably ever asked you to do this.
No.
Right? So, yeah. But so that's, if we were doing this in this session, I'd be like, okay, that's a really good sign, right? That sounds like you have. So then I might have you try patterning it with like a squat, right? Or like something else before I would even do the internal, because it sounds to me like you're not having any symptoms. You're feeling it happen in your body. So let's already then try to pair it with movement versus like spending time on the internal exam maybe right now, right? Depending on what you were being seen for. So anyone else feel it? Like, yeah, this feels great. I can feel it all
I
happening.
felt good.
Yeah,
You feel it?
I still didn't feel my belly move, but I felt everything.
No, you felt like your
yeah.
pelvic floor was contracting.
Yeah.
Great. Did we get anything?
A little bit, yeah.
Little bit. Good. Okay, so that's a good indicator, right? That you're actually, so sometimes people will be like, I don't feel anything happening down there at all, right? And then I'm like, okay, let's go right to the internal, right? Like, let's see, are you actually, sometimes people are actually getting a contraction, they just don't feel it, right? And then sometimes people are not getting a contraction, and then it helps them to have the feedback from my fingers there in different ways to like get a better contraction. But so then we would go to an internal exam. But so pelvic position can help a lot with the way that your pressure is down on your bladder and down on your organs, right? The breath can also help. So the ribs can also help. So if we stand up, now everyone's standing, right? So we find that neutral pelvis, and that's where you should have, like, you can feel the bones, right? And you can also feel like there should be a little curve under your low back. Then the next thing I want you to think about is my weight entirely in my heels, in my toes, or somewhere in the middle?
Middle.
Middle?
Well, now I'm more middle. At first I was my heels.
See, she's cheating. Yeah, so heels, right? So a lot of us end up in our heels for various reasons, right? So when we do this shift back, that's usually for people going to automatically cause them to kind of tuck and go forward with the pelvis. And then the ribs are either going to come down and back, or they're going to flare up this way, right? So the ribs can go different directions in terms of compensating for what your pelvis is doing. So what you want to aim for is your weight about in your midfoot, right? Because that's where it's designed to go, is not all the way in the heels, not all the way in the toes, but right about in the midfoot. And then we want to see, is my pelvis now stacked over my feet, right? So I should be able to see my toes. I should be able to see most of my foot. And then is my rib cage stacking over my pelvis, right? So you can kind of feel, again, like if you go pinkies on your ASIS, and then you find like the bottom corner of your rib, those should be kind of lined up, okay? So if your ribs are forward of your pelvis, now we have like a little bit different alignment between your diaphragm and your pelvic floor. So if your rib cage is facing this way and your pelvic floor is facing this way, they're not going to have very good communication, right? So that's another place where you can get a breakdown and have some incontinence or some leakage because they just don't have good alignment to one another, right? So posture and breath mechanics are super, super important for pelvic health. And I often have people like, if you can't feel the Kegel at first, let's tweak your posture, let's tweak your breath mechanics, your rib cage position. Now, can you feel it better? And oftentimes you can, right? So you can try that at home. You can say, okay, am I normally in my heels? How does my pelvic floor contraction feel there? Versus if I get in a little bit more Pilates style of posture where I'm aligned, do I feel like I have better access to my pelvic floor? And sometimes it's I have better ability to contract it. And sometimes it's, oh, now I can relax it. Like I couldn't let it go before, but now I feel like I can relax it, right? So for some people, that's more important, is the relaxation phase. So once you have that awareness, then you can start to look at some of your exercises where you're like, can I coordinate this with my movement? And can I optimize my mechanics with my movement where I can pull and now feel it as it's happening if you couldn't before? Questions about any of that?
It probably helps when you wear like minimalist shoes, right? Like flats. And...
Not necessarily in terms of alignment.
Mm-hmm.
Yeah, not necessarily. It depends. It depends because some people have a very, very flat foot. And so if like my mom, for example, I mean, her arches are just literally flat on the floor. So if you have a lot of overpronation in your foot, then your knees are internally rotating. Now your hips are internally rotating. We talked about pelvic floor is attached to the hips, right? So now your hips are internally rotated, so your pelvis is going to compensate for that. Now your posterior hip muscles are in a lengthened position. Your pelvic floor is potentially compensating for that. So sometimes the thing to do is to say, okay, we need more support in the foot, right? And that might help with your incontinence because now your whole limb is better supported. Because my mom could do all the foot strengthening in the world. That's not going to get her arches back, right? She needs support. So some people, it's just, they're genetically like that. Yeah, so not necessarily. It depends on your foot and what you want to do and how your body's compensating.
I want to be taller.
I'm not going to take your shoes away. I'm not going to take your shoes away.
My brother's like,
yeah, I think
get
people
rid of
are
those
funny.
shoes.
Like these trends come out, you know, like, oh, everyone should be barefoot running, or everyone should be in these stability shoes. Like, no.
I do feel better though, like in the gym when I have barefoot shoes. Like they're in my cart. I just changed before I walked in. But like wearing like more minimalist shoes are much better. Like when you're like weightlifting and
I like a variety. Like
do?
sometimes, when I go to the gym, I worry about weights getting dropped on my feet,
Oh,
so
yeah.
I wear like my normal shoes. But like when I weightlift at home, I'm usually barefoot, like literally barefoot, because I know it's good for my foot strength, right? And it's good for my balance. But then when I'm like, obviously, if I'm out running, I'm not gonna go without shoes on, so I'll use like my runners. But yeah, I mean, it depends on your foot, right? Feet are unique, and so just like with any other part of the body, you can sometimes play with things and see like what works for my body or what doesn't work for my body. You can't really make blanket statements about stuff like that.
just gonna have to try different things.
Yes.
Exactly.
Definitely.
Wow, thank you.
Yeah.
Any questions, ladies? No?
Cool.
Thank you so much.
My pleasure.
Fantastic.